Assalamu alaikum.
Yes, Dr. Hassan. Can we start? We have about 10 participants and is there. So I'm thankful to Dr. Hassan and CMH Rawalpindi for taking the initiative to present in this virtual vascular surgery general club. The format of this will be that first the supervisor will go through why the paper was selected and what are its key messages and what is its clinical significance. Then the fellow, which is today is Dr. Aisha Masood, will introduce herself and then actually go through brief review of that article and will give critical analysis. We'll expect the participants to actively engage in this activity and give their views and points for last 10 to 15 minutes when they are there. They can actually send me the any queries or question which they want to ask. So with that, I hand over to Dr. Essen to give why this paper was selected and what is its clinical significance. Thank you.
Thank you, Dr. Zia, for the introduction and also for organizing the meeting. Every one of us who have the chance of dealing with the vascular patient, they know that these patients are very frail and they have significant comorbidities, which are usually mainly cardiovascular. And just please wait for a moment. These vascular patients have got a significant chance of having a cardiovascular event during their routine admission as well while in the hospital. So we frequently see the patients who are admitted in the hospital for one reason or another. They suffer either an MI or stroke or some other major problem while they are admitted. So, and this incidence of cardiovascular problems, they increase after lower limb revascularization. In order to prevent that, many researchers have come up with a lot of ideas, and starting with the combination of, starting first of all with antiplatelets, and later on with antiplatelets and warfarin and antiplatelets and some other NOACs like dabigatran and apixaban. There was some improvement in the number of cardiovascular events, but this was actually overshadowed by a lot of bleeding incidences. And then came the COMPASS trial, which showed that there is a significant improvement in cardiovascular related events, but at the same time, the patients have also improved lower limb revascularization and decreased number of acute lower limb events. So based on the COMPASS trial, then this VOYAGER PAD trial was designed, and this was published in March 2020 in New England Journal of Medicine. And then the paper under review specifically focuses on the number of reduction in the number of ischemic events after lower limb revascularization in patient taking a combination of aspirin and Rivaroxaban. So this is very important for us because our patients, the vascular patients, have a significant incidence of cardiovascular related problems, but this can be improved if they take this dual drugs like aspirin and Rivaroxaban. So Dr. Aisha will further elaborate on this trial and its implication. So over to Dr. Aisha.
Thank you, sir. Assalamu alaikum. So, VOYAGER trial was published in New England Journal of Medicine in March 2020. It is an acronym for the Vascular Outcomes Study of aminosalicylic acid along with Rivaroxaban in endovascular or surgical revascularization for peripheral arterial disease. The hypothesis was VOYAGER's trial showed that Rivaroxaban plus aspirin is superior to aspirin alone at preventing major adverse limb events and major adverse cardiovascular events. Background of study, why this study was conducted. The rationale was that previously there were 3 studies which showed that after lower extremity revascularization, there is 4-fold increased risk of acute limb ischemia with a hazard ratio more than 3 of all these studies. After acute limb ischemia, outcomes are poor and repeated revascularizations are frequently required. And most of the outcomes after acute limb ischemia were limb related. That is recurrent acute limb ischemia in 24% of the cases, amputation in 27 cases, hospitalization in 54%, and 63.2% patient needed repeated peripheral revascularization. This is the same. So in these patients, the efficacy and safety of Rivaroxaban was uncertain, which was studied in this trial. Conclusion of this trial was that in 1 in 5 patients undergoing lower extremity revascularization experienced the first adverse limb event or cardiovascular event in spite of aspirin in all patients, statins in 80% patients, and clopidogrel in half of the patients. And the addition of Rivaroxaban 2.5 mg daily reduced first events by approximately 15%. That is 39 patients who were.
Probably we have lost Dr. Aisha. Dr. Essen, are you able to listen me, please?
Yeah. Yes, sir.
Yeah, so probably I do not see your slides. This is very important discussion which you have said. Dr. Essen has rightly said that peripheral vascular disease is quite prevalent. These patients are at high risk of developing cardiovascular and limb-associated adverse effects. And there have been novel methods to actually decrease these risk factors, adverse effects, and one of them is this Rivaroxaban. Do you want to continue your presentation?
In the VOYAGER trial, it was seen. It was shown that Rivaroxaban can reduce the primary events, major adverse limb events, and major adverse cardiovascular events. But the rate of total vascular events was not studies or not analyzed in this trial. So another paper was published on the results of this paper by and further analysis was done to understand the rate of total vascular events reduction with the use of Rivaroxaban. And for this paper was published.
This is very great discussion going on. Probably Aisha is not able to upload the slides. One thing to understand is that VOYAGER trial was a landmark trial in I will say in vascular surgery, which normally in peripheral vascular disease, patient presenting with limb ischemia and severe rotation usually treated with lifestyle.
Can you see my screen?
Yeah, now we can see it. Yeah.
I am also sharing my screen. Aisha can present it on my laptop.
Yeah. What was unknown, the rate of total.
Can you see the slides?
Gigi, we can see the slides, and this is very pertinent point, which was known that the total events of the lower extremity adverse effects was not known with this trial, and they continue to follow up and publish this study. Although VOYAGER trial did shows that use of low dose Rivaroxaban 2.5 milligram twice daily with aspirin compared to aspirin only in patient undergoing peripheral revascularization do decrease adverse limb events and also vascular events. But what is the total impact of that? That was not known. And this is very good follow-up study. And that I see on your slides, that is what was unknown. Yeah, can you continue, Aisha?
In a pre-specified analysis to investigate the number of first and total vascular events in peripheral arterial disease patients undergoing lower extremity revascularization, and the effect of Rivaroxaban on reduction of these events is unknown. And this study was done to evaluate the efficacy of Rivaroxaban on first and total events. These are the certain basic definitions which will help to understand the article which is being studied. Major adverse MACE is basically the major adverse cardiac events, and MALE is major adverse limb events. Major adverse cardiac events include sudden cardiac myocardial infarction, sudden cardiac cardiovascular death or ACS, and the major adverse limb events include acute limb ischemia or any major amputation. And it's International Society of Thrombosis and Hemostasis major bleeding definition is that any patient, symptomatic patient with fatal bleeding or bleeding in a critical area or organ, or bleeding causing drop in the hemoglobin level of 20 gram per liter or more, or leading to transfusion of 2 or more units of whole blood or red RCCs. Primary efficacy outcome is defined as how effective the Rivaroxaban is in reducing the major adverse limb events and major adverse cardiac events. And the primary safety outcome is how safe the Rivaroxaban is in causing or in reducing the bleeding episodes. Basically, 2 types of outcomes were studied in this population. The effectiveness of the Rivaroxaban in reducing the MALE and MACE events, and in how much safe is in terms of bleeding episodes. This is a graph showing the comparison of the total primary events in the placebo group and the Rivaroxaban group, which was lower in case of patients who used the Rivaroxaban. And similarly, the total vascular events were also reduced with the use of Rivaroxaban over a period of almost 3 years. So study design was randomized study. This is a consort diagram showing the randomization. They were all the patients used the aminosalicylic acid 100 mg daily for, and the clopidogrel was at the investigator's discretion. There were 2 arms of the study, placebo arm and the Rivaroxaban arm, in which 2.5 mg twice daily Rivaroxaban dose was used. It was a randomized 1:1 ratio double-blinded study. It was stratified by the revascularization approach, either surgical procedure or endovascular procedure with and without the use of clopidogrel. Patients were followed up to every 6 monthly, or event-driven, or what was, if there was any particular event after primary revascularization, then follow-up was more frequent, and total median follow-up was of 2.5 years. Primary efficacy endpoint was a time to first acute limb ischemia, major amputation of vascular etiology, myocardial infarction, ischemic stroke, or cardiovascular death. And the primary safety outcome was thrombolysis in myocardial infarction, major bleeding. This is the same thing. Total number of enrollees were 6,564 patients. Duration of follow-up was almost 2.5 years. And median patient age was 67 years. Percentage of female patients was 26%, and percentage of diabetics was 40%. Inclusion criteria were aged more than or equal to 50 years. Lower.
Are you people able to hear Dr. Aisha? It is there. Usman, Jamil, and Amar is here with us.
I'm sorry, we can't hear her.
Okay, but
no, sir, we can't hear Dr. Aisha.
So whatever the discussion which has been done is very important, and that she was talking about the VOYAGER peripheral arterial disease trial, and that is was a double-blind actually study that actually came after the COMPASS trial, and it actually stands for the vascular outcomes study. They take Y for the study. From the study of aspirin, they take ASA along with Rivaroxaban in endovascular or surgical limb revascularization for peripheral arterial disease. This was actually to check the efficacy and safety of low-dose Rivaroxaban and used with aspirin in high-risk peripheral arterial disease patient who was undergoing lower extremity revascularization. Because at one end we see that COMPASS trial, which shows that in patient with peripheral vascular disease, it decreases the adverse limb events. but we know that patients who undergo peripheral revascularization are at higher risk of developing these complications. So this study was made for patients who were undergoing either surgical or endovascular intervention for peripheral arterial disease. This was a double-blind study, and it included a large number of the patients. There were 6,564 patients, and it was a multi-center study. There were 34 countries which was involved. There was 10% of the patients from USA, and they were actually randomized into two groups. One group was taking Rivaroxaban 2.5 milligram twice daily with aspirin 100 milligram, and other group was only taking the aspirin. It is very good to know about the criteria. What was the inclusion criteria in these patients, and what was the exclusion criteria in this patient. Meanwhile, if someone can actually contact Dr. Aisha or Dr. Hassan, if they can contact, and we can join it up. So nearly most of these patients was on some type of already some clopidogrel, or they were taking the statins for that. And it is very important they took a very robust method. That is, they take a method of taking the thrombosis in myocardial infarction criteria for checking the bleeding incidence in these patients. And then what they found that it decreases the incidence of the adverse effect. Means in patients, primary events occurs in 508 patients assigned to Rivaroxaban, and in 584 assigned to placebo, with Kaplan-Meier events rate estimated at 3 years of 17.3% and 19.9% respectively, with a hazard ratio of 0.85. So, and that was very good because it decreases the incidence, and secondary outcomes also decreases. So, and this was a continuation of the study which Aisha was presenting. I hope she is back and she can continue from the same presentation. Ji, Assalamu alaikum, Aisha.
Should I carry on?
Yeah. No worries. You can continue. I was just actually getting them engaged, the participants, why this study was done and why this study follow-up is very important to look from a vascular surgery point of view. Yeah.
So we were discussing about the inclusion and exclusion criteria. Exclusion criteria was revascularization for asymptomatic disease, acute limb ischemia of less than 2 weeks of duration, acute coronary syndrome of less than 30 days, any current major tissue loss, or a need for antiplatelet or anticoagulation therapy other than aspirin or clopidogrel, and need for long-term dual antiplatelet therapy and high risk of bleeding were excluded from the study. Other salient features included indications for revascularization, in which claudication patient for 77% and patient for critical limb ischemia for 23%. Type of revascularization, surgical intervention was done in 35%, and the endovascular hybrid procedures were done in 66% cases. Mean ankle brachial index was 0.5. Principal findings for primary efficacy outcome and a primary safety outcome. The primary efficacy outcome included cardiovascular death, acute ischemia, major amputation, myocardial infarction, stroke that occurred in 17.3% of the Revaxo aspirin group compared with 19.9% of the placebo with aspirin group. And p-value was significant, that was 0.0085. This association was similar among these tested subgroups. The primary safety outcome included that bleeding, thrombolysis in major in the myocardial infarction, major bleeding occurred in 2.7% of the Revaxo aspirin group compared with the 1.9% of the placebo group. Again, the p-value was significant, 0.06. Among diabetics, major bleeding occurred in 2.4% of the Revaxo group compared with the 1% of the placebo group. Secondary outcomes were acute limb ischemia in 5.2% in the Revaxo group compared with 7.8% of the placebo group. International Society on Thrombosis and Hemostasis, major bleeding occurred in 5.9% of the Rivaroxaban group patients compared with 4.1% of the placebo group. Intracranial hemorrhage was 0.6% in the Rivaroxaban group compared with the 0.9% in the placebo group. And the p-value was not significant. This is basically the category of total events. Primary endpoint events included the acute limb ischemia, major amputation of vascular causes, non-fatal myocardial infarction, non-fatal ischemic stroke, cardiovascular death, and other vascular events included the peripheral revascularization and venous thromboembolism, VTE in patients. So the Rivaroxaban group total vascular events were 2,186, and in the placebo group it was 2,528, and the total number of vascular events were 4,714. This is the diagram showing the patients who had first and total vascular events over a period of 28 months. Total number of patients were 6,564, and primary endpoint events were 1,092, and over a period of 3 years, the total vascular events were 4,714. Second vascular event by the type of first non-fatal vascular event. The patient who survived the first non-fatal vascular event, in those patients, 60% patient had the second events after first peripheral revascularization, in which other type of vascular events, which were peripheral revascularizations or venous thromboembolism, in the Rivaroxaban group, it was 499, and in the placebo group, it was 593 patients. Patient with major adverse cardiac events, Rivaroxaban group had 73 patients, and placebo group has 76 patients. Major adverse regarding major adverse limb events, 118 patients were in the Rivaroxaban group, and 163 patients were in the placebo group. Similarly, the patient who had undergone other peripheral revascularizations after the first successful revascularization, who needed further revascularization for any type of vascular event, they were 302 in the Rivaroxaban group and 349 in the placebo group. So the first and subsequent event reduced with the use of Rivaroxaban. 61 events were reduced by the use of Rivaroxaban in the first event, and in the second event it was 94, and the third event it was 44 events, and there were further reduction in the vascular events with the use of Rivaroxaban. So there were 342 fewer total vascular events with the use of Rivaroxaban versus 61 fewer first vascular events. So with the use of Rivaroxaban, subsequent events could be reduced at a larger number as compared to the first primary event. So conclusion was that in VOYAGER trial, among 6,564 randomized patients, there were 4,714 total first and subsequent vascular events, including 1,614 primary endpoint events and 310 other vascular events. An estimated 4.4 primary and 12.5 vascular events per 100 participants were avoided with the Rivaroxaban over 3 years. So these are the certain points about the VOYAGER trial. The interpretation of basically the results of the VOYAGER trial. Among the patients with lower extremity arterial disease undergoing revascularization, Rivaroxaban was associated with a reduction in the major adverse limb and cardiovascular events compared with the placebo aspirin group. And there was 2.6% absolute risk reduction in cardiovascular death, acute limb ischemia, major amputation, myocardial infarction or stroke compared with the placebo group at 3 years. The absolute benefit of the regime appeared to be greater among those with both peripheral arterial disease and coronary artery disease. It was also observed, regardless of the baseline clopidogrel use, benefit for Rivaroxaban versus placebo was similar for endovascular and surgical revascularization and for critical limb ischemia and non-critical limb ischemia. Rivaroxaban was associated with a similar frequency of TIMI major bleeding. However, there was increased incidence of ISTS major bleeding compared with the placebo group. Intracranial hemorrhage was similar between the treatment arms. Rivaroxaban was beneficial without excess harm among participants more than 75 years of age. Drug-coated devices were not associated with increase in the mortality compared with the non-drug-coated devices. Rivaroxaban was beneficial at reducing major adverse cardiac and limb events irrespective of the drug-coated device use. Then comes the discussion on this trial. In this trial, which exclusively enrolled a broad population undergoing lower extremity revascularization, nearly 1 in 5 in placebo arm suffered the primary composite outcome at 3 years. Addition of Rivaroxaban 2.5 mg twice daily to aspirin reduced this risk by approximately 15%. And the benefit was already observed 3 months after treatment and constantly increased over the entire study period. Study may answer further questions, and subsequent subgroup analysis hopefully will lead to even more evidence. Use of clopidogrel in this context is under evaluation in terms of its utility and bleeding risk when primary treatment strategy is aspirin plus low-dose Rivaroxaban. Then comes a critical analysis of the study. There are certain questions, although this study is very profound and it can be applied to daily routine practice in the vascular surgery. There are certain questions which can be further evaluated regarding the extent of benefit in the surgical subgroup compared with the interventional subgroup. Certain procedures and technical details may affect the long-term outcomes, and patients' baseline anatomy may predict the limb risk and the absolute benefit of the therapy. Or will these results will lead to a more aggressive invasive treatment policy in order to increase the quality of life by maintaining the mobility and enabling secondary and tertiary prevention. Results from the VOYAGER trial complement and further extend the observation of the COMPASS trial, which observed marked reduction in the acute cardiovascular events and limb events in a broad population of stable patients with peripheral arterial disease with polyvascular disease. In contrast with these two trials, prior trials of antithrombotic therapy with anticoagulants in patients with peripheral arterial disease have not shown this efficacy and rather have demonstrated unacceptable bleeding risk. In addition, previous evidence for antithrombotic strategies following percutaneous intervention and surgical reconstruction was weak, and it was merely based on subgroup of patients with coronary artery disease or broad atherosclerotic populations. There are severe limb outcomes such as acute limb ischemia and amputation rates, if even reported, were typically secondary or exploratory outcomes and therefore have only limited prediction. So the implications on clinical practice, we should routinely be using aspirin and Rivaroxaban after revascularization in our patients. And the dosage of Rivaroxaban, which was studied in this study group, was 2.5 mg twice a day versus we can use also 5 mg. Doses below 5 mg are required in divided doses in order to maintain adequate trough levels in the blood to be effective. Then comes the effectiveness of the drug. Is it most effective in our study, in our population, our patients? And then the close follow the patients already is very necessary. Many patients become non-compliant to the drug and their financial issues. So we have to take record of these things as well, and we can also think of other alternative neuro-oral anticoagulants. So thank you, and any questions?
Thank you, Aisha. That was very well presented, and you have nicely actually presented the critical analysis of this article. So I will like if the participants have any points to discuss, can raise their hands and we can share it up. So Dr. Amar has a question. Do Amar, you want to ask this question? Yes, please.
Thank you, Dr. Aisha, for a great insight on this very relevant issue. I think a couple of things I would want to ask. Number one, they made a comparison between Rivaroxaban plus aspirin versus aspirin alone. But if you look at the previous trials, particularly if we talk about landmark trial, we know this for a fact that clopidogrel in terms of monotherapy has better outcomes, prediction of outcomes as compared to aspirin. So, did the authors specify, was there any particular reason for not doing the analysis versus clopidogrel alone and choosing aspirin only? Because clop, as we know, has a better relative risk reduction rate than any other drug. This is what I'm quoting from the Capri trial. And secondly, the added advantage of using clopidogrel would be probably, in my opinion, cost and compliance, because it is cheaper than Rivaroxaban. And secondly, in terms of compliance, if we take Rivaroxaban 2.5 BID versus clop would be a single dose. So, did they talk about any particular reason for not comparing this with clopidogrel? And the other question would be, the majority of the participants in this study were claudicants, somewhere around 75%, if I'm not wrong. And the best results they showed in terms of reduced hazard ratio was around 0.66 was for acute limb ischemia. And acute limb ischemia was excluded in terms of participants. So isn't this a bit contradictory? Because the best results are in terms of prediction, they're saying that this reduces acute limb ischemia, but on the other hand, they are excluding participants if they are having acute limb ischemia. So these are two things. Why not comparison with clopidogrel, and number two, excluding acute limb ischemia patients? Thank you.
That's a particular question. But regarding the use of clopidogrel with aspirin, it can be further clarified with the authors of the study. But I think they used aspirin with the Rivaroxaban. And in the study, initially, it was also mentioned that patients were using clopidogrel. It was on investigators' discretion. Some patients were using clopidogrel and some patients were not using clopidogrel. In a detailed analysis of the original VOYAGER trial, it was mentioned that the patients who were using clopidogrel and who were not using clopidogrel both had the same results. With they in both of those arms, the use of Rivaroxaban was beneficial. It was not there was no increased bleeding risk, but particularly they did not compare the clopidogrel use with the Rivaroxaban. This can be our research question in further papers or what we can study in future.
Right. There is one more thing, the Capri trial basically compared aspirin and clopidogrel. Whereas there was another trial, Charisma trial, which compared the combination of aspirin or clopidogrel in preventing the cardiovascular deaths and ischemic events. So that did not show any significant benefit, which would have translated into the clinical practice. As you know, even the cardiologists do not recommend giving dual antiplatelet for a long time. There can be only specific reason for using dual antiplatelets, like after placing a drug-eluting stent. Otherwise, there is no clear benefit of actually putting the patient on dual anticoagulants. So clopidogrel in some cases may increase the bleeding risk. So that is the reason that clopidogrel or the combination of aspirin and clopidogrel was never actually that translated into the clinical practice. Now, about this trial, this VOYAGER trial, the thing is, there is a nice paper from I think from some Dutch author, and it is based on the vascular patients in Dutch vascular registry. Now, they say that the people who are actually VOYAGER eligible, if you see the actual patients in real clinical practice, there are only 27% of patients who are VOYAGER eligible patients. They are in the clinical practice. And on average, the actual patients are older, they are more frail, have more comorbidities, and have a greater bleeding. So how are we going to actually use the conclusion of this trial in our clinical practice remains a debate. And I think all of the vascular surgeons should actually assess the patients individually. They should assess their bleeding risk and then start the patient on Rivaroxaban. And this is one thing that the translation of these results into the clinical practice remain open to debate. Now, whenever you read a big trial, there can be some faults in the trial design, and the conclusion which are drawn by the authors may not be completely right. So we need to read the paper completely and see what are the possibilities. Now, the first thing about this paper is that it is funded by Bayer. Bayer is the pharmaceutical company that produces Rivaroxaban, but that doesn't mean that they might have done something wrong. But this is the reason that after every paper, you are asked to disclose your disclosure statement, and you're asked to disclose whether the authors were funded by certain pharmaceutical agencies or whether they have affiliation to certain agencies. So this is the reason. So first of all, remember, this trial was funded by Bayer, and many of the authors, they have accepted contribution from Bayer in terms of various grants or various consultancies, etc. So the other thing is that, you need to understand the importance of primary outcomes or primary safety outcomes or primary efficacy outcomes, because these are the outcomes around which the trial is designed. Any trial is designed. The calculation of the total number of patients should be included in the trial is based on the primary outcomes or the primary safety outcomes or efficacy outcomes. So in the VOYAGER trial, the primary safety outcome was the first event. Now, the secondary analysis or the secondary outcomes are usually, they may be right, but since they are not actually the primary outcomes, so any secondary analysis may not be right. So you have to be careful when you read the conclusion based on the secondary outcomes or the secondary analysis of the trial. So that may or may not be right. So, and there are certain other objections which were raised on this trial by many authors. They are available on the internet and you go through that. So these are some points that needs to be highlighted, and everyone of us should know that before we start using the results of this trial. So any other question or any comment?
Yeah, thank you, Dr. Hassan. That was very good, actually, comment. We have one hand raised by, I suppose, one of the participants, but these are the two important points raised by Dr. Ammar. And one is that why not use a clopidogrel and make a trial for that? So you have to understand that peripheral vascular disease is dependent on a atheroma. The atheroma become vulnerable, and when this vulnerable, the first thing is actually platelet adherence, and that platelet adherence release, when the platelets adhere, they release some factors which activates the coagulation pathway, intrinsic and extrinsic. That leads to in situ thrombosis, and that in situ thrombosis can exaggerate the existing ischemia, and patient can present with a worsening claudication, or they can present with critical limb ischemia, or they can present with a stroke, or it can embolize. So there are two different mechanisms. One is the platelet adhesion, and one is the coagulation pathway, which is here. Aspirin and clopidogrel works on the antiplatelets. They can stop the platelets to adhere, but the thrombotic part, which is we need a strong antithrombotic medication to stop it up. We have level 1 evidence that either aspirin and clopidogrel as a monotherapy is quite effective in reducing the risk of these in peripheral vascular disease, and we do advise it up. In patients who go intervention, we sometimes advise the dual antiplatelet, aspirin and clopidogrel, but although we have no evidence for that, there is no strong evidence. This is the evidence which we get for the coronary vessels, coronary vasculature, and we actually implement it. But for peripheral vascular disease, monotherapy is recommended. Despite this antiplatelet therapy, there are patients who develop these cardiovascular events. For example, they develop adverse limb events, they develop cardiovascular events. So there was always need of using novel thrombotic medication to decrease that risk. There were trials using warfarin And unfortunately, they were not accepted much because there was a lot of adverse bleeding risk and there were a lot of bleeding episodes. So then the Rivaroxaban came, and then there was a trial which was done in the coronary patients, and that shows the efficacy of decreasing the coronary events in the coronary patient. So this led to the trial that it has been Rivaroxaban has been checked instead of the clopidogrel. Second very pertinent point, which Dr. Ehsan has shown, we should not take it as a blank. We have to go through the inclusion and exclusion criteria of this study. The exclusion criteria, they did not include those patients who has asymptomatic peripheral vascular disease or mild claudication. They did not include those patients who has recent acute limb ischemia or major tissue loss and have severe kidney disease. And this was a French trial. What they did, they actually observed all those patients in their 4 major hospitals, all those patients, and observed how many actually patients match the inclusion and exclusion criteria of those patients who may be the candidate of the low dose Rivaroxaban. They come to know that about 2/3 of the patients are not come into the inclusion criteria and excluded from the study. So when you have to prescribe this Rivaroxaban, you have to prescribe for a selective group of the patient, for which we have the evidence, not for all these patients. So this is a comment from my side. I saw one hand raised, probably who wants to ask any question is welcome. Khalil, you want to ask any question?
Assalamu alaikum, sir. My question was that they excluded the major tissue loss. In our setups, most of the patients who are coming with critical limb ischemia or with the major tissue loss. In this scenario, how will you approach the patients with according to this trial?
Yeah, the evidence is not strong. For that, we definitely would need the treatment. I will like the opinion of my colleagues on this. This is very pertinent because these patients with having I'm not sure why they have excluded those patients with a major tissue loss if they are going for surgical and endovascular treatment. One of the critique for this paper, VOYAGER, when they have limitation of this study was that they have not revealed the patients who have undergone which type of surgical treatment and which type of endovascular treatment. So there were limited detail of that. And we did not knew that how many patients have the bleeding due to the wound-related bleeding, especially the patients who are going surgical treatment. That was not actually revealed in the VOYAGER trial. Thirdly, there was very much, there was actually a limitation or a critique, I will say. They have seen why they have selected the criteria, which is very selective. For example, they use the bleeding in thrombosis in myocardial infarction. This is a special type of the criteria used for the bleeding, which is selective. So there are few questions which are there. To your question, if I say for the evidence base for a patient with a major tissue loss, this criteria did not include those patients. So probably this was due to they may be their higher risk of bleeding. That may be one of the reasons they have not included, and we have no evidence for that. I will like to listen the views of others on this point.
Now, I just want to add something. Now, if you go through the trial, there was another strange thing that they included all the patients with peripheral vascular disease from iliacs downwards. Distally did not include the patient with aortoiliac disease. So in our setup, we see a lot of patients with aortoiliac disease. So these were the patients who were excluded from the trial. Another thing was that there were about 14% dropouts from the trial. So these patients actually were enrolled initially, but they did not complete the trial period. They were dropouts. So they were not actually the part of the final analysis. So this was another drawback or limitation of this trial. As far as the major tissue loss is concerned, I think the reason that they did not include those patients was that maybe they were the patient who also needed some sort of major amputation. And that might be that could have actually distorted or changed the whole course of the follow-up of those patients. So this might be the reasons.
Yeah.
Sir, might be in the patients with the tissue loss have a multi-level disease and disease burden is more compared to the claudicant and the chronic limb ischemia. That might affect on the outcome of their trials, so they excluded this patient.
Yeah, that is good. There are two hand raised, one by Sabi and then by Dr. Nadeem. So first, Sabi, you can ask the question.
Assalamu alaikum, sir. Sir, I would like the comments of the experts on this. How would you interpret this into your own clinical practices? Now that we have discussed the negatives of this trial, when would you be willing to start the patients on Rivaroxaban plus aspirin, and when you would not, considering all these implications and contraindications?
Yeah. So, Dr. Hassan, you want to comment? Or Dr. Umar is with us also. So, going to your question, I will go to the evidence. I will actually thank the VOYAGER investigator for doing this study, because this is very high risk patient. And if some medication which has low bleeding risk can make a difference in the overall outcome, that is great. I will add a patient who is more than 50 years, who have documented moderate to severe peripheral arterial disease and is undergoing any intervention. For example, they are going for surgical or endovascular operation. As soon as the risk of the bleeding decreases, I will add 2.5 milligram of Rivaroxaban into that patient, especially the patients who have the disease below the external iliac artery. So this is the fact that I will continue to add antiplatelet, aspirin, and 100 milligram along with the anti-lipid medication. I will not come back from the lifestyle modification and also optimal medical treatment, that is controlling the diabetes, quitting the smoking, and seeing for that. But if there is any, because you have to understand, there were two major limitation of this study. If you go to that, there were very few women who has been enrolled in this study, and secondly, there were very few blacks which has been enrolled in this study. So this study cannot be generalized. We have to be very cautious when we give in our population, and especially for the women when we are actually going for that. This is the point which I have to raise. Then Dr. Nadeem is here. Dr. Nadeem has raised the hand.
Thank you, Dr. Azia. Thank you, Dr. Hassan and Aisha, for this nice presentation. So 2 points. One is regarding why they have excluded the patients with tissue loss. So when I was doing my fellowship in Barcelona, I was the part. That center was the recruiting center for VOYAGER PD trial. And we also collected some patients. So it is right that a lot of patients were excluded because of the very stringent inclusion criteria. One of the reasons why they have taken out the patients with major tissue loss is because the approach and the treatment of every physician and every center is different. If a patient comes with ulcer or a black toe, and especially if it has a superadded infection. So, and obviously that approach towards the treatment of this tissue loss will make a difference, can make a difference on the overall outcome of this trial, which is amputation. So probably this is one of the reasons, even in that same center, different physicians tend to have a different opinions about the same wound. So this may be one of the reasons, and this study has been done in more than 25 centers across the Europe. So that is one of the reasons they probably have excluded the patient with major tissue loss. The second point about the Sabi, the point which he has raised, I think it's very important to look at in our clinical context. And I think the concept of NNT, which is a number needed to treat, is very important. So we have to calculate that how many number of patients you have to subject to this dual treatment in order to get a patient to reduce to prevent the major event, a cardiac or limb. And in this case, I think the NNT would be quite high. To see the difference in actual practice, you have to treat a lot of patients. And you also have to keep in mind about the risk of bleeding, which is higher, in fact, statistically significantly higher as compared to the aspirin only. So these are the two things which probably we have to understand while applying this trial in the real life. Thank you.
We are coming close to our session. There's a hand raised by Dr. Farid. Dr. Farid, you can go for quickly for your short comments before I actually thank you, all the participants, especially from CMH Rawalpindi and all the participants from all over Pakistan who has came for this meeting. Thank you. Dr. Farid.
Thank you, Dr. Zia. No, I would not take much time. Just a small comment has been said is very valid, and I think it is easier to comment or critique on a study compared to when you are actually performing a trial. I think these trials have important messages for us, but yes, we should always be careful while implementing these trials in our practice because of the different population. The point to make is we don't have Rivaroxaban 2.5 milligram in our country with Bayer multiple times. So another question remains that whether Apexaban 2.5 milligram twice a day as good as Rivaroxaban, because that drug has never been used in these trials. So that is another question apart from all said up till now. Thank you.
Yeah, actually, this trial discussion opens a lot of opportunities for us to do studies, which we different centers can work together. We can actually work together to see what are the population which we are receiving, which are actually can be included for using the Rivaroxaban. We can use alternative antithrombotic medication and see what is their effect. So this leaves a lot of opportunities and opens a lot of discussion. So thank you everyone for actually actively participating, and that has been great interaction and that has been great learning. Thank you, Dr. Hassan, Dr. Aisha, and all who have actually participated and give the comment. Thank you for that. We'll inshallah meet on the 4th Wednesday of this month with some educational activity. So thank you for that. Assalamu alaikum.